I'll introduce our speaker, Dr. Oloomi, who all of us know very well. He's an intensivist. He's been with us for, 5 years now? And he's unique in that he's the only medically boarded person in our intensive care unit, boarded in medicine, pulmonary, critical care. He was Subramanian's, right hand for, 5, 6 years at Lenox Hill. And, and, then, and then you ran the unit at Maimonides too. Okay, so he's going to talk to us about coagulopathy in the ICU.
Today I'm going to talk about management of the coagulopathy in cardiac surgery patient. And let me start my talk with the actual case. He's a 62 years old man, underwent first time cardiac surgery with valve sparing root replacement. Preoperative medication was a statin and a beta blocker. Intraoperatively, patient received 52,000 units of the heparin and reversed at the end of the case with 250 milligram of the protamine. Empirically, in the operating room, received 4 units of the FFP, 2 units of the platelet. In the ICU, he was warm. Hemodynamically, patient was stable, but bleeding around 150 cc per hour. Coagulation tests obtained on the ICU arrival, indicating ACT of 120 second, platelet of the 115,000, INR 1.3 with the PTT of 37 second, and the fibrinogen level of the 120 milligram per deciliter. What therapy should be considered right now?
Exploration.
How many hours has he been bleeding?
That's just came. That's the first hour. That much bleeding.
Just monitoring.
Just monitor the patient. So, how many of you wanted to give a run of the factors? FFP, platelet, and cryo, and probably blood, because by the time the blood bank release all those factors that we're requesting, patient is going to lose another 300 to 400 cc of the blood.
I'm a big guy, so does he have about a fat? I mean, do we consider about heparin rebound?
Do you want to give a protamine? If somebody wanted, would you just raise your hand? Those who wanted to give a protamine. What's this? 1, 2, 3, 4. Okay. And how many of you want to, after 3 hours, patient come to the ICU, take the patient back to the operating room because of the bleeding? So by 3 hours, what I mean is around 500 to 600 cc of the blood is coming constantly out.
So if the one who closed it have a high index of bleeding and he dumped in the first 3 hours, there is no reason to wait further.
So do you want
to the one who closed the chest?
Yes, I agree. But my question is, so we want to sit on it, just give it protamine and wait, and the patient lose another probably 500, or might be a stop. So hopefully, I try to shed some information in the next few slides. Just as a reminder, in cardiopulmonary bypass, venous blood drain to the reservoir. After oxygenation, it will pump back to the aorta. The circuit needs to be primed with a liter or liter and a half of the crystalloid. This causes hemodilution and lower concentration of the coagulation factor plus the platelet. Moreover, blood is interfacing with the non-endothelial surface. So whenever large amounts of the blood are interfacing with the non-endothelial surfaces during a procedure, it's critical to anticoagulate the blood. So we use a massive amount of the heparin, almost around 5 to 6 times more than the amount of the heparin we use for the pulmonary embolism. The other important factor is the sternotomy. And all associated injury to the tissue, particularly precardium, release massive amounts of the tissue factor and cause additional hemostatic activation. Because cardiopulmonary bypass patient can bleed, blood needs to be recycled. As a result, some of the product of the hemostatic activation can circulate it back, such as tissue factor, and some of those might be filtered, like a platelet and coagulation factor. Therefore, cell saver by itself has a both procoagulant and hemodilutional effect. Finally, at the end, we reverse the effect of the heparin. The perceived cause of the bleeding post-cardiac surgery has changed over the decade since 1960s. Bleeding is happened when the balance between these mechanisms, dilution, activation of the hemostasis, fibrinolysis, which I'm going to talk about later on, and the return of the activation product from surgical field, increasing dosage of the heparin that we do use it nowadays, and currently persistent usage of the antiplatelet therapy until the time of the surgery tilt this balance to the right. Despite greater understanding of the mechanism of the coagulation and associated transfusion guideline, allogenic blood product usage can be as high as 50% per STS data. So just wanted to look at in the next few slides. I'm just going to mention about the role of the cardiopulmonary bypass on three things: heparin, second on platelet, and then about the fibrinolysis. End product of the intrinsic and extrinsic pathway is thrombin, which convert fibrinogen to fibrin. Antithrombin neutralize thrombin and other activated coagulation factor. In presence of the heparin, the rate of the formation of these inactivating complex increased by a factor of several thousands. The dosage of the heparin gradually increased from 250 to 400 units per kg, sometimes as high as 600 in the United States through the survey was done in 2010. It's generally accepted the ACT of 420 to 482nd, which correlated with the heparin level of 3 to 5 units per milliliter. ACT, as you may know, is a point of the care test that a sample of the whole blood is activated by activators such as phospholipid, and the clot formation measured by magnet, optic, or some of the old machine by the flow. Nowadays, in the cartilage of the ACT, we have a different concentration of the prothrombin. So when we can calculate indirectly heparin level, just not the direct level of the heparin, is the indirect. This is important to adjust the dosage of the prothrombin because excess prothrombin can cause adverse reaction, including antiplatelet properties and bleeding. ACT is a highly sensitive test, just remember that, but it has a very poor specificity. Keep in your mind, in Sinai, when patients leave the operating room, heparin level of the zero. Most of the patients, they leave the operating room with that level. ACT might be abnormal, and the reason for the abnormality of ACT, because as I said, is poor specificity of the test, might be secondary to the low fibrinogen or low platelet level. What is heparin rebound? Heparin rebound is reactivation of the heparin effect, occurs 5 minutes to 5 hours after neutralization with the prothrombin sulfate. For this phenomenon, we can repeat the ACT. But keep in your mind, ACT may be abnormal secondary, as I said, to the low platelet or fibrinogen. What's the best test to diagnose heparin rebound? If we send the heparin anti-10A, some of the center definitely they're doing it, one of our neighboring hospital they do, on the first post-operative blood. If the level is more than a 0.2, then we can suspect it's a heparin rebound phenomenon. Cardiopulmonary bypass and the effect on the platelet, most of our patients are thrombocytopenic, more than just the dilutional effect. It assumes thrombin activated the platelet, and it adheres to the circuit with the monocyte and leukocyte. Post-pump platelet are semi-active. Although there is a post-operative platelet lesion, both thrombocytopenia and dysfunctional platelet, but there is no consensus as to what extent this contributes to the blood loss in the post-operatively in cardiac surgery patient. With usage of just want to mention this point, that the usage of the antiplatelet, chance of the post-operative bleeding, re-exploration, and the transfusion is higher. If they are not stopped before the surgery, recommendation is to hold the medication 5 to 7 days, and in urgent cases, with the expense of 1%, just 1% increase in the risk of the myocardial infarction. It's a nice study actually done in England. Because 25% of the patient are non-responder, and some work has been shown that the platelet function can correct within 3 days of the stopping this medication, we can measure the function of the platelet either by the TEG map or by the multiplate area under the curve more than a 50 if we use the ADP, and for the TEG is the inhibition less than a 20%. Actually, Dr. Puskas, around a few years back, he had a case which we did it for him. We did a TEG mapping. Keep in your mind, performing platelet function on a patient with a platelet count less than 100,000 is not advocated. If you have a thrombocytopenia in the operating room with a platelet of 80,000 and you perform the functional assay of the platelet, is no value for it. So last part, cardiopulmonary bypass and fibrinolysis. In normal hemostasis, we know any thrombin that escape activated plasminogen to plasmin, and this plasmin change the fibrin to FDPs. During cardiopulmonary bypass, production of the thrombin is increased 10 to 15 times. Interestingly, fibrinolysis system are get activated during both on-pump and off-pump surgery. Hyperfibrinolysis following coronary on the bypass, just when patient go on pump, not off pump, as a cause of the bleeding is account about 6 to 8% of those patients who bled. A decade ago, we used to use aprotonin significantly. I'm pretty sure the people in the front row, they remember we use it. But after publication of the BART study, Bayer Pharmaceutical removed this drug from the marketing. Although it still is available in the United States for the compassionate use, it is a resurgence for the usage of this one in the Europe and Canada. Health Canada has approved its usage with a strict regulation. Personally, I don't think this aprotonin is going to come back to the market in the United States because of that report came up. Having said that, we have nowadays lysine analogs such as TXA and EACA. Both inhibit the activation of the plasminogen to plasmin, and in higher dosage, as I show in the red arrow, inhibit the activation of the or conversion of the fibrin to the FDB by activation of the plasmin. Aprotonin is the strongest in reducing blood loss, blood transfusion, and possibly return to the operating room after cardiac surgery. EACA is the least effective. Tranexamic acid is somewhere between. Just keep in your mind, post-operating use, if you use a TXA, increase the seizure activity to the patient, something roughly around 3.2% when they did a head-to-head study. Whereas EACA seems to have the least side effect. What is important about this agent is this agent, generally speaking, do not differentiate between the pathological and the physiological fibrinolysis and prevent all form of the fibrinolysis, leading to the possible thrombotic side effect. It would seem prudent to select the right agent in the right patient, knowing the circumstances. For those of you who are interested, I definitely recommend that you look at the antifibrinolytic in cardiac surgery by Dar, published around a few years back. And the last medication is CU 2010, which is under investigation. So let's go back to this patient that we have. So we talk about the heparin, we talk about the fibrinolysis, and the generally speaking. Do you want to give a prothrombin to this patient that you mentioned? Are you still you want to give it?
PTT and the ACT aren't bad, but it's 110 kilograms.
So the answer is no, because as I said, we said the ACT is sensitive test, is normal, is no role for it. If the ACT was abnormal, we can argue both ways. but definitely this one is not the heparin rebound. Does anybody want to give a platelet to this patient?
Already got platelets, right?
You already gave it, right? Yeah.
Exactly. So already has been given. The number is more than 100,000. And we said it, I said it actually a few minutes ago, is no consensus as far as the role of the thrombocytopenia. Definitely when it's more than 50,000 and the chance of the bleeding. What about we give a TXA or antifibrinolytics agent? Okay, I have to answer, you have to bear with me. So let's get how we monitor the coagulation. Prothrombin time and APTT, first of all, just let you know, it takes about 30 minutes to 60 minutes. Sometimes our lab taking more time to get it back. Another problem with them, they just show initiation phase of the clot formation. Is a time dependent. Some older study has shown a clear relationship between the abnormality of these two tests and excess bleeding after cardiac surgery, but recent study, including 2011 paper by Kozek, couldn't show these tests to be able to discriminate between who is bleed and who is not. I can tell you my personal experience is same to certain degree. Remember, first, PTT is only accurate to the heparin level of less than 1 unit per milliliter. After that is not a sensitive test. Second, PT and PTT show gross abnormality of the intrinsic and extrinsic pathway. But we know that isn't no relationship between the concentration of the factors except the fibrinogen and the post-op bleeding. Several study has been shown. If you check the level and the level is low, not necessarily patient is going to be bleed, except the fibrinogen. So I talk about the ACT in thromboelastogram, the whole blood and reagent incubated, as you said on the upper diagram, to heated cup, and a pin is introduced into the sample, basically measuring viscoelastic property of forming of that clot. In TEG, they call it thromboelastogram. The cup is oscillating. In the ROTEM, or there is abbreviation for rotational thromboelastometer, the pin is going to be rotated. So as you see it on the diagram, all right, so if you see the lower diagram, is a time what is going to happen on the horizontal line, you have a time. On the vertical line is amount of the tension or impedance is generating on that pin, and it's going to be a graph. So you see it. I put the nomenclature for the TEG on the upper part, and for the ROTEM in the lower part. Is a time, we call it R, if you see on the beginning, is going to be the time that the blood is initiating. Then is a K, is a clot formation. Then you see the MA is a maximal amplitude, which is show the maximum strength of that clot. And we know the normal physiology, when the clot is formed, then the fibrinolysis is right away is acting. And after a while, you see the curve is going to divert. And then we call it, empirically after 30 minutes, we call it fibrinolysis, or when the 30% the curve comes down. So it's a dynamic process. Keep in your mind, depend on the reagent that we added to this 0.5 cc of the whole blood, then we can measure. If we block like a tissue factor, then we can measure the extrinsic pathway. And then if you had something to block the platelet, like they call it cytoclasine D, then we can inhibit the platelets. And then indirectly, we measure the fibrinogen. That's the most important thing. So depend on what reagent we adding to that cup, we can measure the different property of that clot formation. The ROTEM, it has a 4 channel, we can run it at the same time. Why I'm mentioning this one? Because if you see that lots of the study has been published, particularly in the European country, I'm just going to get later on it, is emphasize on this, they call it FibTem, Fibrinogen Thromboelastometer. There's a study, actually, if you look at most of the European center, they're doing it, except England, is a fibrinogen by this way indirectly measured within 10 minutes. Normally take to 30 to 60 minutes in the laboratory. We randomly, I just personally, I look at the last week when I assigned this talk, look at our patient. We measured the fibrinogen level, but it took more than 2 hours or the patient was in bed 6. So if we measure this fibrinogen, it's gonna take time. Okay, in summary, so let's see what we know about and what we don't know. So far, we know nationally around 5 to 7% of the patient lose more than 2 liters of the chest tube drainage. Up to 5% require re-exploration. Roughly about half of the patient who bleed is the surgical bleed, 50-50. It depends on the service, and all of us, we know that in mitral service, the rate of re-exploration is less. We know allogenic transfusion has been
In mitral service or in mitral patients?
But I want to emphasize it. It depends, as Ahmed said, it's the surgeon how comfortable when the patient come out of the operating room. So roughly, we look at it. I think that's my experience, and I heard it from other people. The mitral patient, the chance of the re-exploration in the operating room is significantly less. That's right. I just put in the risk factor. You're absolutely right. We know what else we know. We know allogenic transfusion has been a significant cause of the morbidity. We know after the published result of the TRACS study, transfusion requirement after cardiac surgery, and editorial by the JAMA that they mentioned it, that was in 2010. Blood transfusion as a quality indicator in cardiac surgery. Now it is a quality indicator. We know any test, all algorithm that prevent empirical administration of the blood product. I just want to emphasize to this. Any type of the test that you're doing it that prevent this empirical administration of the blood product likely will reduce usage of the blood product. So we are not good as far as the clinical estimate who is going to bleed and who is not going to do that. And we identify the high-risk patient preoperatively. As you say it, those who get the reduced sternotomy, aortic surgery, particularly aortic root. We know nowadays if somebody be anemic, go to the operating room, chance of the bleeding is higher. I mentioned about the role of the antiplatelet. We know long bypass run definitely increase the chance of the bleeding, and the hypothermia, and in the intensive care unit is the controlling of the blood pressure. But we don't have an optimal test. Interestingly, we don't have a universal definition of the preoperative bleeding. I encourage all, at least the fellows, to look at the paper published almost 2 years ago by Doc and colleague for the universal definition of the preoperative. And they look at the 8 different variables, how we want to scientifically look at this periop bleeding. So, management. What we have it has been recently suggested for the FFP patient, when they are in trauma patient, it's been suggested that if you want to give a FFP, give a FFP to the RBC with the ratio of 1:1. The role of this practice in cardiac surgery has been questioned. And we look at it, a study actually published it. If you do this regimen, definitely cause more of the volume overload, respiratory failure, and multi-organ failure. In recent systematic review was done in Europe, the effectiveness of the FFP in bleeding and the trauma patient was scrutiny. Keep in your mind, plasma is not a good source for fibrinogen. To increase fibrinogen level from 1 gram per liter, we needed roughly around 33 milliliter of the plasma per kg, ideal body weight. And this is for 70 kg person, we need a roughly liter and half of the FFP to increase the fibrinogen. Second thing is a cryo is obtained by a thawing of the FFP at the 1 to 6 degrees centigrade. Then centrifugation is happen. And then resuspending that centrifugal with the protein in a plasma, and they refreeze it. Cryo is a multi-donor required inventory according to the blood type and required time for thawing and pooling before transfusion. No wonder when you ask for the cryoprecipitate, it's not going to be ready right away. That's the reason behind it. 1 bag of the cryo, a standard dose has between 8 to 10 units of the thawed FFP. In Mount Sinai, we have a 5 instead of the 10, so the amount of fibrinogen is almost half. If you a standard bag roughly has between 1.5 to 2 gram of the fibrinogen, so in Sinai, roughly we should have around 750 of the fibrinogen. It has a factor 8 and 13. Cryo is a multi-donor product with a no antiviral processing. Most of the European country, except the England, they don't have it and they don't use it. Guideline suggested that cryoprecipitate should not be used to control bleeding related to the low fibrinogen level if a specific factor concentration are available. Lastly, about the few lines about just talk about the platelet. Platelet generally administered on the platelet count less than 100,000. Nowadays, we have a point of care. They call it multiplate. It function basically is an analyzer according to the platelet aggregometry. So just measure the impedance of the platelet. It has a 4-channel, and we can add ADP, collagen, and we look at the function of it. But as I mentioned it before, if somebody has a thrombocytopenic, there's no value for the functional assay. Just kind of a little bit emphasize on the fibrinogen, and these, I can tell you last probably 3-4 years, several papers published, particularly in cardiac surgery, about the role of the fibrinogen. It has the highest concentration factor in the blood. It used to think the level of the more than 1 gram is sufficient postoperatively. Current guideline, they recommended level more than 1.5 gram per liter. We do measure fibrinogen, as I mentioned it to you, on arrival in the ICU by the Klaus method. Klaus method, we added thrombin, and the clot formation time is recorded via a spectroscopic analyze. Keep in your mind, again, might be falsely elevated if the patient get heterostoch. Those centers that use a heterostoch, that was one of the pitfalls. In point of the care, as I mentioned it, the maximum amplitude, MA, is correlated with the fibrinogen. Several studies has been published regarding the role of the fibrinogen in the cardiac surgery. Some of those I just mentioned it briefly. We look at the CABG patient preoperatively, level less than 3 correlated with the post-op surgery as a predictor. We look at it in the ICU arrival, more than 2,000 patients on the observational prospective study, look at the fibrinogen level, and we can predict who is going to bleed in the intensive care unit. In some prospective study, which was a small, fibrinogen reduced the transfusion compared to the placebo. The result was amazing, 2 units versus 13. Multiple studies show reduction of the allogenic blood transfusion in ascending aorta replacement. Is a trial by the name of REPLACE. They call randomized evaluation of the fibrinogen versus placebo in the complex cardiovascular surgery. What they mean by complex, most of it was the aortic. The last patient actually signed for the study was in September 2014. I just talked with the company. Definitely, they don't have a safety escort. The result is not published. They are looking to put the primary primary outcome. They were looking at it to publish it. So we'll see what's going to be. And the fibrinogen concentrate is from the pool donor that undergo purification, viral activation, and removal of the process, and do not require cross-matching. So just want to tell you the study, because I know a few years back when they wanted to start a study, it was just giving compared to the placebo. So when the patient was in the operating room, some people, they get the fibrinogen on the complex and some they are not, and they look at the amount of the transfusion. Hopefully we'll see the results of this study. What about the prothrombin complex concentration? It has factor 2, 9, 10. Some of those batch, they have a 2, 7, 9, and 10, but the standardization is happening with the concentration of factor 9. It has a protein C, S, and heparin in it. We currently use for the urgent reversal of the vitamin K agonist. Keep in your mind, we have 5 different products in the market nowadays in the United States. We have more than 3 in Mount Sinai. They are a little bit different. Some of those, like FIBA, they have a more concentrated of the factor 7. Some of those, like Bibolin, which we don't have it in Sinai, it has a lower factor 7. The key point, if a patient has a fibrinogen level less than a 1.5, when you give a prothrombin concentrate, it won't work. So you have to give the patient either FFP, bring that level up, and then prothrombin concentration. Kcentra has a thrombotic complication of 1%. If we use with the dosage of the 50 mics per kg, limited data is available depending on the center. And actually, definitely, it has a role in several case reports, first reported in 2012 when we use a NOACs and the patient goes on the cardiac bypass surgery. On that scenario, the dosage is significantly higher to 50. We are awaiting the result of the randomized controlled trial in Netherlands for the liver patient. When you give a prothrombin or Kcentra prothrombin concentration is a protocol base. So it means if you should by requirement have an INR more than a 2. That's the reason when you call the blood bank, they're not going to release the product, and then they're going to call the fellow. So if you have it, you want it, needs the attending to talk with them. And then, as I said, is a very protocol-driven factors. 2 other factors, we have factor 7. There is off-label usage of this one. First time personally I used it in 2004. We bring the medication from Pennsylvania to use it in one of our patients. I remember it was open chest, the blood bleeding is stopped. Unfortunately, later on patient stroke. It was not a good outcome for us. Then we did a randomized placebo control. Gill reported in 2009. It was a reduction of the allogenic transfusion for cardiac patient, but increase in the thrombic event on those who were treated. Sporadic data are available as a rescue measure, and the dose that usually we give it is 30 mics per kg. Interestingly, all those case reports, if you look at it exclusively, except one of them, all of them in cardiac surgery prior to the Novo 7 or recombinant factor 7, they receive a cryo and platelet. Factor 13 is a recombinant factor, is promising in 2006, but when we look at the safety and efficacy of a study, did not show any benefit in transfuse reduction. In some limited usage of it on those who measure this factor 13 pre-op, if there is less than 30% of the normal, and we don't want to give this antifibrinolytic, is promising, but I don't see, honestly, any role for it. So let's go back to this patient again, after all this information. So now what you wanted to do? Any change, or still you want to give a?
Do we have a tag?
The tag on this patient, I don't have it, but no, I don't have the tag. Retrogradely, I look at the tag, But anything else is bothering you on this test? Result. Fibrinogen. So the treatment of the choice, if you want it, you just give it 2 pack of the cryo on the beginning, and then, or if you have a fibrinogen concentrate, is the ideal body weight, you have to calculate it. So is 110 kg, let's say the ideal body weight was on this patient 75 kg, and usually you want a 50 mics, so the maximum give around the 3 to 3.5 gram of the fibrinogen. The more fibrinogen you give it, because some people, they don't look at this actual body weight. And as I said, another key point of it, just remember, the fibrinogen that we have in Sinai doesn't, the cryo that we have in Sinai doesn't have that much product. Yes, you have in the blood bank. Just want to tell you, a few years back, I personally adopt above management step for those who are not bleeding for the surgical reason. As Dr. Ahmed said, the first and most important thing, if you see it, usually if I have a bleeder in the ICU, I just ask the surgeon if the patient was oozing or what's happening in the operating room. And this algorithm is a little bit different shape. First, it's introduced by Gerald Levy, that some of you might know him as a guru in the coagulation. So let's say if you have a patient, you identify clinical bleeding. What is going first in your mind is a time. So I usually begin coagulation tests, and you can ask most of the physician assistant or somebody with a resident working with me or nursing. First thing I usually ask them to call the lab that we need the stat result of this. Automatically is coming. So back of my mind, I have that heparin rebound phenomenon, especially if I know the ACT has been abnormal. I might consider it. And used to be thinking when we use lots of the, this antifibrinolytic medication, if I suspected through the TEG, at the end of the case, somebody run another TEG, I might consider TXA. Then is the whole point is to reassess the bleeding in the short period of the time. If any intervention done as far as the product or factor was given to the patient, the lab has to be repeated. We cannot be, sit on the first lab and go for it. Then if the result come back, I usually for the platelet less than 100,000 and the patient is bleeding, I might just give it 1 unit of the platelet, not more than that. If the fibrinogen level less than 200 is a cryo versus the fibrinogen concentrate, nowadays is available. And if the INR is more than 1.5, I give the FFP, not more than 2 units. Because for that concentration of the factor, 2 units of the FFP should be enough post-open heart. I never treat the isolated abnormal PTT, and there's no value for it if you want to look at it for heparin rebound. And then at the same time, you should be considered, is a point that you have to keep the patient normothermic, and then acceptable hematocrit. So when we order and the patient losing the blood, it's patient, they need the blood, some hemoglobin for this coagulation pathway. So you don't want to give a factor and keep the patient severely anemic. And then, as I said, if the life-threatening hemorrhage patient has it, then we have to do the massive transfusion protocol, which I mean it by massive transfusion. The first is a call to the blood bank, and then consider this prothrombin concentration, or rarely, as I said, they didn't use that. I don't personally have that much experience of the recombinant factor 7. I just finished the talk. Although I outline for you a strategy, it won't work by itself. For proper management of the bleeding, every single aspect, such as blood bank, keep a patient warm, and other things should be considered. Thank you.